said, the backbone of the whole treatment of cardiac issues, whether it's cardiac surgery, whether it's cardiac ischemic heart disease, valvular heart disease, or anything. Well, I'll just like to go through a few slides and go through a couple of major trials that have happened on statins, and then we'll go into a little discussion with that. Start. Use of statins to treat the risk, not cholesterol. That's a very important statement, as it is the statins. Everybody says that, you know, the statins are why are the statins being used when your cholesterol is normal. I will come to that at the end of the whole discussion. Why statins are important besides lowering cholesterol. So, what are the benefits of lowering the cholesterol? This is a meta-analysis of 38 primary and secondary prevention trials with more than almost 100,000 patients in total. And basically, it shows that the mortality in the coronary heart disease is reduced by the use of, as you can see, by the use of statins, lowering the cholesterol as much as we can over the number of months that we are. The more we use the statins, the lower it gets the cholesterol, and the mortality rate increases. Relationship between changes of LDL-C and HDL-C levels and the CHD risk. Now, as you all know, total cholesterol is one thing, but LDL-C cholesterol is the bad cholesterol, and HDL-C is the good cholesterol. So it is not just important to reduce the total cholesterol levels, but also it is so important that we should decrease the LDL as much as we can. That's the goal, and increase the HDL. So if we have a statin or a drug which can do both the purposes, it corrects the ratio and helps things very much. 1% decrease in LDL-C reduces the coronary artery disease risk by 1%, and 1% increase of HDL reduces the risk by 3%. So increasing the HDL is equally more important as reducing the LDL. Risk factors for cardiovascular disease. Now, they are always, as you all know, they are always divided into modifiable and non-modifiable, remediable or not remediable risk factors. Now, if the non-remediable one is very simple, if you have a family history, a personal history of heart disease, you have had heart disease before, or your family has a strong history. If you are a male and your age is above 50, all these factors you can't change. So you can't modify these. You can't change your gender, you can't change your age, you can't change your family history. But these are all fixed. But what modifiable factors we have, at least we can control those on top of the medication that we take. Modifiable factors, as you all know, smoking, dyslipidemia, blood pressure, diabetes, obesity, dietary factors, thromogenic factors, lack of exercise, weight, excessive alcohol consumption, excessive weight control. All these are modifiable things which you can always readjust themselves in your life. Levels of risk associated with smoking, hypertension, and hypercholesterolemia. This is a very important slide. Hypertension, smoking, and high cholesterol, they multiply with each other. It's not just they add 2 and 2 plus say 4, but they multiply. If you add hypertension to smoking, it increases to 4.5 times. If you increase cholesterol to hypertension, 9 times more. If you combine smoking with cholesterol, 6 times more risk. And if you have a combination of all these, it's a 16 times more risk of getting IHD if you smoke, if you have blood pressure and high cholesterol. So that's how it multiplies. Atherosclerotic cardiovascular disease burden. Now, this is just a statistics that the WHO has estimated given. 16.6 million people die of cardiovascular disease worldwide each year. 16.6 million. Cardiovascular disease contributes to approximately 1/3 of the global deaths. So that's a big number, 1/3. Only 1/3 cardiovascular, 2/3 rest of the mortalities. In 2001, 7.2 million deaths from heart disease, 5.5 million deaths from stroke. This is 2001. Now you can imagine how much would it be now. Next. Atherosclerotic cardiovascular disease burden. Yeah, we have discussed that. Now, ACC, American College of Cardiology, and AHA, American Heart Association, Blood Cholesterol Guidelines 2013. These are the few guidelines which the American Association has given, and now the European Society of Cardiology also agrees to it. 4 statin benefit groups. Which groups are the important groups which would benefit a lot from statins? Now, there are 4 groups in that. One is the individuals with clinical atherosclerotic cardiovascular disease, acute coronary syndrome, or a history of MI before, stable or unstable angina, coronary other arteriovascular disease, stroke, TIA, peripheral vascular disease in the past. That these are one individual, which any of these histories are the ones who will benefit the most from statins. Second group is individuals with primary elevation of low LDL, low density lipoprotein C, more than 190. Third group is individuals between 40 and 75 years of age with an LDL of 70 to 190. And the fourth group is individuals with clinical atherosclerotic disease or diabetes who are 40 to 75. So these are the 4 kind of group of people who will benefit the most from statins. Now, what are the kind of statins? We are coming to that. Moderate intensity statins for more than 30 to 50% LDL reduction for primary prevention in patients with diabetes. These are, you use moderate intensity statins for these if you want to reduce the LDL by between 30 and 50%, and in a diabetic patient in which you need to lower the cholesterol. High intensities. What are high intensity statins? For primary prevention in patients with clinical cardiovascular disease and diabetes, for more than 50% of LDL reduction, for patients with clinical cardiovascular disease, which is acute coronary syndrome, MI, stable, unstable angina, stroke, TIA, other coronary arteriovascular disease, and in patients for loading dose for who are undergoing the PCI. So these are the kind of people who need high intensity statins, which basically this is the group of people that needs that. Thanks. Different intensity statins. Now, what are high intensity statins and what are moderate intensity? High intensity statins lower LDL on average by approximately more than 50%, and moderate intensity they decrease it by less than 50% but more than 30%. What are high intensity then? Atorvastatin 80 milligram and rosuvastatin half the dose of 40 milligram. This is the dose for high intensity statins. Moderate intensity statins are atorvastatin, rosuvastatin, simva, pravastatin, lovastatin, flavastatin, but all in a lower dose. 10 milligram, 20 milligram, except for pravastatin for 40 and lovastatin for 40 milligram. These are moderate intensity. High intensity statins for primary prevention in patients with clinical atherosclerotic cardiovascular disease and diabetes. First of all, there are a couple of trials that I will give a reference of. You all know about Jupiter trial and all other trials that I'm going to discuss. Jupiter trial was the use of statins in primary prevention, an intervention trial evaluating rosuvastatin. Jupiter. Patient, almost 90,000 subjects screened, 17,000 patients randomized to rosuvastatin and half of them to placebo. And well, we'll go into the details of that later. Patient roll. Age, placebo and rosuvastatin, this was a comparison. Age 66 in both, male patients 61%, race white 71%, black 12%. So these are the inclusion criteria. Blood pressure of 134/80 in both groups. Next. Medical history: current smoker, rosuvastatin में 15%, in placebo 16%. Family history of heart disease 11% in both. Metabolic syndrome 41% in both. Aspirin use 16% in both. So they are equally, comparatively equally same kind of people, same kind of patients. Next. Jupiter endpoint. What was the primary endpoint? Cardiovascular death, first cardiovascular death, or non-fatal stroke, or non-fatal MI, unstable angina, or arterial, somebody who needs arterial revascularization. This was the primary endpoint. Percentage of patients with the primary endpoints, as you can see. Placebo group, as the years go by, 1, 2, 3, 4, 5, as you see, the curves diverge. Rosuvastatin much lower than the placebo, which shows a significant reduction in all these primary endpoints once somebody is on proper dose of rosuvastatin, which is 20 milligram. Next. Jupiter summary, as I was discussing, a 44% reduction in the primary endpoint of major cardiovascular events, and which is patients observed in patients who received rosuvastatin 20 milligram compared with placebo. A 20% reduction in total mortality was observed in patients who received rosuvastatin 20 milligram compared with placebo. In Jupiter, long-term treatment with rosuvastatin 20 milligram was well tolerated in nearly 9,000 study participants, which is very, very good. For patients with clinical atherosclerotic disease, the role of high-intensity rosuvastatin slowing atherosclerotic process. As you can see, the arterials is a cross-section of the arteries, in which you can see the progression of the atherosclerosis till the last slide, last picture. Meteor trial. This was one of the very landmark trial in 2007. American College of Cardiology, it was presented. It basically measures the effect of intimal thickening by giving rosuvastatin. They measured the intimal thickening before and after giving the rosuvastatin. Meteor background was to evaluate the effect of rosuvastatin compared with placebo or carotid intimal thickness over 2 years among asymptomatic patients at low risk of cardiovascular disease. Meteor study was again compared with the placebo. Rosuvastatin 40 milligram was given with the placebo, 700 patients there. Rosuvastatin with the placebo, 700 patients there, 260 patients in the placebo group. Primary endpoint and rate of changes in maximum CIMT, which is the cardiovascular, the intimal thickening, the carotid intimal thickening. That was the measuring point in both the trial. Meteor endpoint. Now you can see there is a couple of things. Change in the maximum CIMT with rosuvastatin versus placebo. As you can see, placebo had absolutely no effect. And in fact, the intimal thickening was increasing with time. And as the time goes by with the rosuvastatin, there's definitely negative deflection in that, as you can see. And there's a definite reduction of intimal thickening in the carotid artery, as you can see in the slide. Next. Once again, secondary endpoints, change in the maximum CIMT with rosuvastatin versus placebo. As you can see, the blue in placebo, the intimal thickening was all increasing, but with the rosuvastatin, it definitely decreased the intimal thickening over the time. Next. Again, material secondary endpoint, change in the maximum CIMT with rosuvastatin versus placebo. Once again, it shows the same thing that we are trying to prove before. Next. Comparison of this is the third trial now again. Comparison of the progression of coronary atherosclerosis for two high efficacy statins regime with different HDL effects. Statin study, it is called. Took The objective of the study was to compare the effect of rosuvastatin 40 milligram versus rosuvastatin 80 milligram on progression of coronary atherosclerosis assessed by intravascular ultrasound. So this is a comparison, as we discussed before. That was a placebo comparison, Meteor trials. This trial is basically a comparison of atorvastatin versus rosuvastatin. So double the dose of atorvastatin, 40 milligram was started, and rosuva was started on 20 milligram, 1,400 patients, almost asymptomatic coronary artery disease. And over the time, you can see the results. Both were given simultaneously. There was a screening period, then the randomized period, which was taken up till, and then the IVS was done. Next. Second trial followed the patients, 4,255 patients screened, treated in North America. Treatment for 2 weeks with atorvastatin 40 and rosuvastatin 20 milligram for 2 weeks to achieve LDL less than 116. So after 24 months treatment, atorvastatin was 80 milligram and rosuvastatin was done on 40 milligram. Few patients withdraw, evaluate the final follow. Next. As you can see, change percentage of atheroma volume by the intravascular ultrasound was seen. And as you can see, the atorvastatin was -1 only, and rosuvastatin was definitely significantly more than atorvastatin. Secondary IVS efficacy parameters, once again the same thing, atorvastatin almost -4 and rosuvastatin more than 6.4. This will like 2 more than that, and this is a change in the total atheroma volume. Once again, simultaneously giving both the drugs. Comparison of efficacy and safety of rosuvastatin versus atorvastatin, simvastatin, and pravastatin. Now, this was a bigger trial, which was basically a stellar trial, which compared 4 statins together: rosuva versus atorvastatin, simva, and pravastatin. Next. 6-week multi-center open-label randomized trial, 15-arm trial comparing the efficacy and safety of rosuva with atorva, simva, and pravastatin. 2,240 patients with hyperlipidemia or mixed lipidemia. Patients with more than 18 years of age, stable LDL cholesterol concentration between 160 and 250 at the 2 most recent consecutive visits before randomization. Now here in the stellar trial, rosuvastatin 20 milligram reduced HCl by 52% at 6 weeks. As you can see, the comparison of all the statins, 62% reduction, 52% reduction of rosuvastatin in 6 weeks. Next. Again, this is a comparison of the 4 trials. As you can see, the blue one is the percentage of patients. This is the highest effect of 10 milligram, 20 milligram, 40 milligram, 80 milligram. Rosuva doesn't come in 80, but up to 40 milligram, it has the highest effect on atherosclerotic reversing and preventing the endpoint of cardiovascular disease. Next. Now, take-home messages are: use of statins to treat risk, not cholesterol, which is a very important statement, which means that it is not only lowering the cholesterol, it is not only the number, which lowering the cholesterol number is the only thing that is it, but it is the important thing is that what we are achieving from lowering the number is the risk factor of cardiovascular disease, stroke, end-stage MI. High-intensity rosuvastatin provides superior LDL reduction, definitely. We run 3 trials, provides superior primary prevention, definitely. Provides superior atherosclerotic plaque regression, as we saw with IVS in the 2 trials, and the beneficial for patients undergoing PCI. Whoever is going under PCI, their cholesterol has to be down. Thank you very much. This was about. This was a talk about comparison about rosuvastatin, atorvastatin, and the other trials. One of the meetings that I went to in the USA, and this is 10 years back, and one of the participants asked the speaker that if somebody has an MI, this is important. If somebody has an MI in the hospital and his cholesterol is already 155, yeah, 150, would you still put him on statins? This is very important. The answer was definitely. It is statins not only lower the number of cholesterol, but it has so many other beneficial effects affecting the atherosclerotic process, nitrous oxide process, narrowing of the arteries, and so many other things. So it is irrespective of what cholesterol levels you have. As I said, it is not the numbers. You have to reduce the risk. So statins is the backbone of ischemic heart disease, stroke prevention, atherosclerotic peripheral vascular disease. Statins have to be given. So recently, there was a thing going on the internet and on the WhatsApp messages and everything that statins is out of practice. You know, statins have side effects, and there's no point of using statins ever. But there has been so many thousands and thousands of patients. If we go back in the 70s, Mr. Fit trial, then there was a big trial in the 80s, a miracle trial that came in, and there's so many other trials that have come out which have proved the beneficial effects of statins. Here, I compared 3 trials in front of you to show you the benefits of the rosuvastatin, half the dose of rosuvastatin, which is definitely more effective, and there's like thousands of patients being benefited from this. Hopefully, I am able to convey the message that the rosuvastatin definitely is a preferable statin over rosuvastatin and other statins, though the higher dose has been used. And in my personal experience, rosuvastatin, I've seen less cases of myopathy, less cases of side effects because of the lower dose also. And a lot of my patients are just maintained on 5 milligrams of rosuvastatin, which is a very minimal dose, and patients can take it for life. I hope this was knowledgeable and beneficial for all of you. Any questions, we can always exchange. Yeah, well, because I am an interventionist, and I have been using statins for all my patients, in fact, whoever come in. And I do a lot of PCIs. I always use statins, I would not say a loading dose of statins, but I always tend to use statins after my PCI and tend to put them on a higher dose of statins. The lower, the better. Especially after somebody has had an MI, somebody has had a PCI or anything like that, the lower, the better. So I try to give them higher dose to begin with. Once the cholesterol levels are low, LDL is low, then we can always reduce them down after that. That's it. Thank you very much. Hopefully it was beneficial for all of you. And if there are any questions, you can always write to me on my email or contact me in Umar Hospital, Jail Road, Lahore. Thank you so much.